I am going to talk about reducing waste and some practical ways that you can reduce waste in physiatry, as well as telehealth. So I'll start out by talking about medical waste in general, and then I'll delve a little bit more about PM&R specific waste and what we do and don't know, which is quite a bit. And then I'll talk about some solutions, and then end on telehealth. So healthcare is the second most wasteful industry in the United States, creating more than 4 billion pounds of waste annually. In fact, the healthcare industry produces about 9 to 10% of US greenhouse gas emissions. And this is rising. So from 2010 to 2018, US healthcare emissions rose about 6% to the highest rate among industrialized nations. Now, a large portion of these emissions are generated from the manufacturing and procurement of medical supplies and pharmaceuticals, like single-use plastic, for example, most of which are disposable. Now, 30% of healthcare facilities and an estimated greater than 60% in underdeveloped countries are not currently equipped to safely handle existing waste loads, and that's according to the World Health Organization. Now, not all countries are created equal, so some countries produce dramatically more waste than others, medical waste. So, for example, the United States produces an estimated 17 times as much waste per hospital bed per day than a country like Nepal. In fact, the US healthcare sector generates the most pollution of any national healthcare sector in the world, while spending more and without attaining better health outcomes. So we are not doing a great job of this. We're probably all sick at this point of talking about the pandemic, but the reality is that COVID-19 really increased medical waste, an estimated 10 times, according to the World Health Organization. In fact, PPE alone contributed about 1% of emissions to the UK in 2020. COVID also created a huge increase in single-use plastics, which of course then have to be landfilled or incinerated. Now, this was a trend, the trend of single-use plastics in healthcare that existed before COVID, and it has continued to accelerate afterwards. In fact, I just read a JAMA article about this, how really medical companies are incentivized to make their products single-use and disposable due to difficulties in processing and guaranteeing sterility, and as well as due to the profit incentive of hospitals having to continue rebuying their product. So this is a huge issue and it's worsening. In addition, the global population continues to grow and there is an increased global burden of chronic disease. All of this is going to equate to an increased demand in healthcare, which of course is going to generate more waste. So it's already a big problem and it is getting worse. Now, why is this an issue? Like, why do we care about medical waste? Why do we care about pollution in general? And the simple answer is that it costs lives. So in fact, pollution from healthcare in the US alone caused an estimated loss of close to 400,000 disability adjusted life years in 2018. Most of these DALYs were attributed to our contribution to climate change, and the remainder was due to particulate matter emissions from healthcare. So waste in medicine is clearly a big issue, but what about physiatry, rehab medicine in particular? So we know very little. We are learning more, and Alex is going to talk a little bit more about this too. But overall, we're still a long ways away from even establishing a baseline for our specialty. Now, how do we go about establishing a baseline, identifying prime waste drivers in our institutions? A straightforward and practical way to do this is through waste audits, and waste audits are a systematic way of tracking waste. Most waste audits have been published in an inpatient or OR setting, and there have been very few that have actually been published in an outpatient setting. So outpatient rehab, inpatient rehab units, skilled nursing facilities, LTACs are actually largely unexplored territory in this. That being said, ambulatory services are increasing, and so this is a huge opportunity for research, and of course, the goal of research is then for intervention. What's more, once identified, there are proven ways to reduce waste. So, for example, a low-hanging fruit is educational campaigns, which have been shown to be quite effective, actually, at reducing waste and improving proper sorting. All right, so I was fortunate enough to be a part of a waste audit at my training institution. So this was an academic PM&R outpatient sports and spine clinic. It consisted of 7 attending level providers, as well as 2 nurse practitioners and supporting residents. And the goal of this waste audit was to identify key waste generators to target for intervention and to quantify the environmental impact of waste produced by these clinics. So to do this, we measured waste from a total of 31 randomly selected encounters over a 6-month period. That was from December 2020 to June of 2021. And we weighed all this waste after each visit. So these appointments included new patient visits, follow-up visits, CMGs, in-clinic procedures, and procedures performed in outpatient surgical center settings. We weighed all waste, including paperwork, gloves, exam room table, procedural supplies. However, due to logistical difficulties, we did not include biohazard waste, sharps, or pharmaceutical waste. And so if anything, this is an underestimate of waste produced. What we found was, not surprisingly, procedural waste was the most significant contributor. However, not all procedures were created equal. So, for example, a procedure performed in the outpatient surgical center created up to 6 times the waste of a procedure visit performed in clinic. And in addition, different procedure techniques produce dramatically different waste patterns. So, for example, some providers would individually open components for their procedure and only select what they needed for the procedure, while others would use these prefabricated kits, which would contain, a preset list of supplies, many of which weren't even used during the procedure and would not even be single-use plastics, but zero-use plastics in this setting. And what we found was that for this small clinic alone, we could save an estimated 1.1 tons of waste from the landfill annually, simply by changing the way that we selected supplies for our procedure. So that's huge. I should also mention that there was a big reluctance of recycling companies to accept items that appeared clinical in nature. And so because of this, none of the waste generated during these procedures or in our clinic was actually recycled. All of it would wind up in the landfill. I should also mention that if you are able to recycle waste, it costs significantly less than landfilling waste. For example, waste that was able to be recycled, i.e. waste that did not appear clinical in nature at this institution, cost 7 times less to dispose of compared to solid waste disposal. So huge profit incentive as well. All right, so let's talk about future directions for PM&R waste. I'll start by saying that at least at my institution where this study was done, there was a substantial interest in workplace sustainability among providers, supporting staff, and managers when we surveyed people. So all it needed was a little bit of a spark or a cheerleader to get this going. I will also say that PM&R as a specialty is ideally suited for easy team formation. We already work in teams regularly, especially in the inpatient setting. So we work with therapists, nurses, social workers, managers. And so it's pretty easy to actually introduce a green team element to that when you're already working within a team setting. I will also say that starting as a resident or a student, if we have any residents or students here, is the perfect time to start. Most residents are required to complete a QI project. And so a waste audit, for example, is a very concrete and easy way to complete your QI project. And you also have access to institutional resources. Now, future directions. So we know that rehabilitation medicine no doubt generates significant amounts of medical waste, but we still have to do a lot of work to establish a baseline. And I'm happy to say that Alex is going to talk a little bit more about work that she has done to help establish a baseline after I'm done talking here. But we really need more waste audits to be conducted in an inpatient rehab setting, skilled nursing facilities, LTACs, and of course in other outpatient settings. And this will enable us to start to identify intervention opportunities. Rehab is sort of unique in that our patients use a lot of durable medical equipment, such as wheelchairs, Hoyle lifts, standing frames, home ventilators, you name it. And all of these wear out over time and have to be disposed of. And while there are some recycling programs that exist, the vast majority of these items wind up in the landfill. And we need to do a better job of keeping them out of there. So part of the solutions is reduce. So again, I've harped a lot on waste audits, but they are a good way to identify your primary waste generators and thereby focus limited attention and resources on the most wasteful practices. And they also allow for data tracking. For example, in the waste audit we did, if we could change the practice of where the procedure was done and how the items for that procedure were selected, we could eliminate a ton of waste from the landfill. And of course, you could also just reduce unnecessary procedures because they are far and away the primary waste generator. Solutions you can also reuse. So especially during the pandemic, reusable isolation gowns were a huge topic. I actually also just read a recent article in JAMA about reusable items in healthcare, and that there was no increase in infection with use of reusable as opposed to disposable isolation gowns, versus there was a huge environmental savings. Somewhat more controversial, more rehab specific would be things like reusable catheters. Again, we need more studies to help prove or determine if they are or are not associated with increased infection. That would be step one, to turn towards more reusable items. And then of course, DME, as I already talked about a little bit. And then there's recycle. So an estimated 60% of OR and ICU waste could be recycled. And so if we can get recycling companies to accept clinically appearing waste, which I think we could, it would just take a little bit of work, then there's a potential for a huge amount of recycling of our items. Educational campaigns are quite effective for improving proper waste segregation, which of course is the first step in order to segregate waste properly and to determine what can be recycled or disposed of in the landfill or disposed of in like biohazard waste. They're quite effective. So there's an estimated 3.5-fold decrease in regulated medical waste when an educational campaign is implemented. And this has the potential to have a huge cost savings, up to $100,000 annually for larger institutions. So again, there's a big financial incentive for doing this right too. For those of you who are interested in getting going, and I think that is the point of this talk, is to kind of give you kind of concrete and easy ways to begin to improve sustainability at your institutions. You don't have to reinvent the wheel. So there are already practice management resources available online that can kind of walk you through sustainability initiatives at your workplace. One easy one is My Green Doctor for smaller clinics. It's a free online resource that can be easily implemented. It walks you through the formation of green teams and gives you almost like a set agenda for each meeting on items to work on to improve sustainability of your clinics. For larger institutions, there's Practice Green Health, which focuses more on the sustainability of healthcare institutions. All right, I'm going to change directions now and talk a little bit about telehealth. So at this point, at least in the US, an estimated quarter of primary care visits are now virtual, which is a big change. And a recent systematic review found an average emission savings of 66 to over 300 kilograms of CO2 saved per telehealth appointment, which is huge. One institution found that around 50,000 telemedicine visits they conducted was the equivalent of removing close to 600 passenger vehicles from the road for an entire year. So huge potential for emission reduction in healthcare. Now, there was some concern when everyone was kind of pivoting towards telehealth that it wasn't truly replacing in-person visits. Like for example, you'd have an appointment with your primary care doctor via telephone, and they'd say, hey, I actually need to see you next week in person to examine you. And so instead of replacing your in-person appointment, you just added a telephone visit. So that was a concern. However, the same systematic review found that actually that's not the case. And when they looked back, they found that virtual care was indeed replacing in-person visits and not just adding to them. This is a graph from an article published in the Journal of Climate Change and Health. And this study was a retrospective review of outpatient care at a healthcare system that served over 600,000 members in the Pacific Northwest. it was Kaiser. And it found that due to COVID, when they transitioned a lot to telehealth, which already was uptrending, they found that their overall carbon intensity of outpatient visits decreased about 50% from 2015 to 2020. And that was almost entirely due to increased telehealth utilization. It was not due to decreased volume of appointments, for example. And they estimated a savings from or a reduction from around 8 kilograms of CO2 per visit to around 3.9 in 2020. All right, so that's kind of more broadly telehealth in medicine in the US in general. But what about telehealth in physiatry? I would argue that our population has its own unique mobility and transportation challenges because we work a lot with people with disabilities that make telehealth even more important for our population. They have trouble accessing transportation to appointments. You can imagine your high cervical spinal cord injury patients or your amputee patients or your severe TBI patients who might even be dependent on a caregiver to get them to their appointments. So transportation is a big barrier to accessing care for our population, even more so than I'd say the general population. In addition, our specialties are not uniformly geographically distributed. So where I am in Montana, for example, cervical spinal cord injury patient might struggle to access a SCI trained physiatrist, for example, in the absence of telehealth. So telehealth has the potential to both increase access for our patient population as well as decrease carbon footprint. So it's a win-win. Now, as part of that waste audit study that I mentioned earlier, we actually also collected transportation data. So we asked our patients their transportation method, as well as collected their travel distance using their home address. And we found that an estimated 5,000 video visits in 2020 saved an estimated 270,000 driving miles for these patients, which was the equivalent of about 11,000 plus gallons of gasoline. Now that is enough to drive across the entire United States 97 times or the entire Earth 11 times. And that's from one small outpatient PM&R clinic. I will admit it's in a heavily trafficked and car-dependent region though. Again, if you are interested in increasing telehealth in your practice, if you haven't already, you don't have to reinvent the wheel. So the Human Health Resources and Services Administration has put together a best practices in telehealth page, which has a lot of great resources. And the AMA also has a telehealth resources page that you can access. And with that, there are my works cited, and I'll stop a little bit early for questions.
You know, the title of my talk today is overlapping here with Dr. Lowe. So moving towards a greener practice, specifically looking towards interventional physiatry. So I'll be focusing a lot on interventional musculoskeletal care and spine interventions, but certainly I think a lot of these messages are applicable to other interventional practices, whether it be spasticity management or otherwise. So keep that in mind. And then, of course, as Mark-Ali mentioned, I do have some sustainability associations with some other groups here that are mentioned above. So the objectives of the talk today is really going to be to run through my journey as a person who's interested in researching within this space. And really, it's been inspired a lot by the work that Dr. Lowe has already spoken about and Dr. Alexander. So if there's a little bit of overlap there, it's because these two physicians have really paved the pathway in this space. And the work that I've set out to do is really an extension of that. So specifically, we'll be talking a little bit about the intersection of interventional pain medicine and climate change. And then I'll speak a little bit about the waste problem in medicine specific to this space, and then describe some methods to quantify and survey physician views, as well as to develop a little bit more data. As Dr. Lowe mentioned, there is not a lot out there in terms of how bad we are effectively at generating waste. And finally, I hope that this will leave you with a planted seed by which to engage in other research of your own that may be related to this in the domain in which you practice, whether it's interventional physiatry or some other area of focus within our specialty. So I'm going to start by talking a little bit about why this matters through the lens of an interventionalist. And as we all know, climate change significantly affects human health, and we always think about very clear-cut ways in which this does this, right? So rising global temperatures, meaning extreme weather events, pollution, rise of zoonotic viruses. And we know that this is a concern based on other data to physicians and also to patients. But how is that related to what we're doing on the day-to-day? Well, in order to care for our patients, of course, they're engaging with the healthcare sector. They're coming to see us. And paradoxically, as we've been speaking about, our sector is one of the major contributors to global carbon emissions. And it's really important in the context of healthcare delivery to think about ways to reduce our carbon emissions and our waste. And when we think about treating patients who have chronic pain and who require interventions, we need to really think about what are the components of the biopsychosocial model, right? So pain being influenced not only by the physiological, anatomical, structural issues that might face our patients, but also by the psychological components of pain and also the environmental components of pain. All of these things tied together to give us this phenotype of somebody who has chronic pain, chronic musculoskeletal dysfunction, and physical impairments that obviously are a downstream effect. And several authors, ourselves included in our study group, really argue that climate change related events really can modify all of these different elements of this biopsychosocial model and can contribute to worsening impairments and dysfunction. And that should really be incorporated in our paradigm of thinking. So let me give you some examples. So how this is relevant, how it intersects. So certainly we can think about the spread of infectious diseases, right? Like we had Zika virus outbreaks recently leading to chronic musculoskeletal arthritic type of pain. There is well-documented research that, suggests that there's a relationship between, extreme weather, barometric pressure fluctuations, and musculoskeletal disorder pain exacerbations. And then if we even take a step back even further and we think about what are the main treatment modalities for some of our patients who have chronic musculoskeletal pain, well, it's things like physical therapy, right? So how can we have access to these services if we have extreme weather events that limits people's access to services? So this is a figure from a recent publication in the Journal of Interventional Pain, looking at kind of this idea of the biopsychosocial model and how climate change is a direct factor, in our opinion, at least. One thing that I didn't mention before as well is, or sort of is I think important to elaborate on, is the psychological burden of chronic pain. And there's well-studied associations between exacerbations of pain in the context of PTSD, depression, and anxiety. And unfortunately, climate change related events can further precipitate dysfunction in this domain. And then we talked about biology already. So you can think about, right, the example of zoonotic viruses impacting, right, chronic musculoskeletal pain and joint pain. And then the social aspect of it as well is really important. If people have limited access to the services, which is exacerbated by extreme weather events that are climate mediated, well, this is another issue. And that, of course, ties into the big picture of pollution and extreme weather events sort of perpetuating this cycle. So I think that's sort of the framework by which I think a lot about why this is relevant to our space as physicians who treat a lot of pain. So moving on now to sort of this waste problem. So it's very difficult to study the direct impacts of climate change on pain, but certainly it is an area of research that's worth exploring in the future. So in order to sort of tackle something a little bit more tangible, myself and our working group decided to sort of go back to basics and look at characterizing again the waste problem, because it felt like something tangible, something that we could really address in a reasonable time frame as a starting point. And as Dr. Lowe mentioned, we just need more data in this domain. So we started by looking at, again, this through the lens of interventional pain. And My interest in this topic, probably similarly to a lot of people on this call, stems just from seeing pictures like this over and over again on the day-to-day basis. These are photos from, the interventional suite in which I worked in as a resident a couple of years ago, and you can just see the amount of plastic and just the amount of stuff that we accumulate by virtue of doing the procedures that we do to help, with patients' pain. And what's frustrating is that nobody really knows what happens to this, and nobody really can explain when you query the people in your workplace. Most people can't explain why we have so much of this, why it's all single use, and what happens to it after it leaves. So this sort of introduces, I think, the concept of the lifespan of a product. So if you think about this syringe, right, it has to go through various phases in order to make it into your hands, right? It needs to be, the raw materials need to be produced and extracted, then they need to be manufactured, then there's the distribution. Then this product finally gets used in healthcare. So we do our injection, we, give some local anesthetic through the syringe and this needle. And then at the end of that, it goes into those bins that I just showed, into the sharps container. Maybe this goes into the recycling if you're lucky. And then at some point, it's going to make it to where it needs to go, whether that's general, the general garbage or the sharps disposal. So thinking about kind of the continuum of a product is effectively what's called a life cycle analysis. So this is a systematic analysis of the impact of the entire life cycle of a product, right? The material, the process, and anything else that's measurable throughout the life of this particular thing. And the real goal here is to generate a great understanding of the environmental implications of the things that we use on the day-to-day basis that are likely to contribute in some way to the pollution problem that we have. This is a schematic from the website EcoChain that kind of describes a little bit more tangibly what a life cycle analysis entails. So just the idea of looking at from start to finish what it is that a product is the constitutions of it, and then what happens to it after you use it is really the take-home message. The challenge with doing a life cycle analysis is that it's very challenging for many folks who don't have background in environmental sciences, because it takes into account everything at the individual material level. So it can be a little bit cumbersome to try to think about a way to do this if you don't have specific training, or if you don't have specific access to any component of the part of that particular product's life cycle. So you don't know exactly where it was manufactured, you know who the manufacturer is, but you don't have access to the manufacturing data from that company. So with that in mind, we wanted to still look at, the impact of some of our more common procedures, but wanted to quantify this maybe in using another method. So just to take a step back and re-engage us all here, I do have a question for the audience. So how many epidural steroid injections are performed annually in the United States? This is a study that I'm citing some data from 2015. So maybe something.
Yeah, the most. D.
We have one vote for D. Is it a good vote?
I vote for D.
So in 2015, at least the study in the PM&R journal cited 9 million epidural steroid injections performed in the United States. I'm sure that's more now. The general trend is that the use of interventional procedures to treat pain, especially in the face of the opioid epidemic, has risen substantially. Oh, actually, it's 9 million. So between 9 and 10 million. Good job. So if you think about that 9 million number, and we look at all of this procedural waste, this problem becomes exponential really quickly. And thinking about ways to measure this, certainly one could do a waste audit, right, as Dr. Lowe presented. One could do a life cycle analysis, looking at the individual components of all of the epidural injections that we're doing and looking at them from start to finish. Or you could try to develop another method or use another method that is using publicly available data. So that's what we did. Our goal here was to study basically two different means of which we could do epidural steroid injections, either through the transforaminal approach or the interlaminar approach, and see if we could develop a method that was easy to quantify the carbon footprint and compare the two. So We partnered up as physiatrists with the public health school at our university to do this in the context of a public health class. And we were fortunately able to develop this method. And I think it's kind of interesting because it's pretty achievable. We use what's called the greenhouse gas protocol, which is publicly available on the internet. And this is a method that attempts to basically break down a life cycle analysis, but does it with information that's widely available. So you don't have to know exactly how any given material was produced by the manufacturer, as long as you know how much it weighs and you know what basic material it's constituted from. So if it's a plastic, if it's a metal, what kind of a metal it is. And from there, you can figure out more or less accurately what the carbon emissions associated with any given product are, as long as you have those basic characteristics using this schema. And it accounts for basically the carbon emissions resulting from the production as well as from the disposal. So you do need to have some information about what's happening at your institution, but it's much easier to do using this technique as opposed to doing a bona fide life cycle analysis. So what we did is we looked at one standard industry-produced kit for an interlaminar epidural injection at our institution, and then we looked at a standard kit for a transforaminal epidural steroid injection. And then we applied this method to see if we could, reliably identify the carbon footprint. And we found that we were able to do this. So for our transforaminal kit, this is the kind of the carbon amount that we came up with, 1.3 kilograms of CO2. The interlaminar kit was a little bit more carbon intensive. Generally speaking, we found that the emissions from the kit production generally seem to exceed those from disposal, meaning that our institution did have some good means by which of disposing of products. And interestingly, when we asked the physiatrists who were performing these interventions, all of them mentioned that regardless of what kind of kit, again, these are produced by industry, if we ask them how much of the kits they're actually using, it's a little bit frightful. 62% of the interventionalists reported that they were discarding a large proportion of the prefabricated kit materials, going straight into the garbage, which is a little bit disheartening. So when we look at what these numbers mean, this is sort of the carbon equivalents for the interlaminar kit. This is the transforaminal kit. And you can see here on this graph, we have other things by which we can compare it to. None of these studies are based in our field. These are all from different things. And I think it's important to note that the carbon number that is associated with these procedures is really just for the materials themselves. This is not accounting for the patient driving to the clinic, the lights being on, the fluoroscope being on. This is just for the procedure itself. So of course, this is not a representation of the whole encounter. It's really just of the materials. So when you think about this, it definitely undersells, I think, the big picture, which is the entirety of the patient interaction. But it's important for us to consider, I think, the pieces of the procedures that we can potentially control in the future. So can we do a better job of making these kits and structuring in a way that it's less wasteful? So I'm going to move on from talking a little bit about characterization of waste and moving a little bit towards understanding if people think that this is an interesting field of study. And why that's important is if we don't have buy-in from our field, if we don't have people who believe that this is important, then it doesn't really matter if Dr. Lowe, quantifies the amount of procedural waste, or if I characterize it using a carbon footprint analysis method. If nobody cares, then it's really difficult to move this field forward. So in the space of interventional pain, what we decided to do was ask our society, the IPSIS Society, formerly known as SIS, what the members thought about climate change and what the members thought about waste, for the purposes of seeing, is this something that we can really build off of and try to change people's practices for the better? Okay, so this is a survey that was recently published, and certainly I encourage you to check it out if this is something that you're interested in replicating either at your own institution or otherwise. But I'm going to walk you through really quickly what we found here. So we asked the interventionalists through the International Pain and Spine Intervention Society, what their views on climate change and waste production in this space were. And this was an email survey that went out around the time of the annual meeting. And for those of you who don't know, IPSIS has a membership of about 5,000 members, not all of which are physiatrists, but all of which do have the common thread of doing interventions. And here were some of our results. So unsurprisingly, most of our participants were white males from the United States. But what was very heartening was that 80% of responders agreed that climate change was happening. They either agreed or strongly agreed. And while 78% of people agree that climate change and sustainability are important to them, only 47% agree that it was important to their patients. So perhaps a little bit of dissonance there that, physicians think this is important to me, but maybe my patients don't find this to be as important. In other fields, it's interesting because physicians tend to believe that this is important, but also seem to believe that their patients have a very similar viewpoint. So not really sure why this is a little bit different in the space of interventions. And it was also good to note that these beliefs did not necessarily differ by age or by geographic area. Now, other findings that I think are of interest were that physicians who were in non-leadership positions are more likely to disagree or strongly disagree that climate change is important to them. They also seem to disagree that it's important to their patients, and they also really don't think that society should advocate for climate policies. So in other words, if you were in a leadership position, which was defined as either a practice group leader in the private setting, you were a program director, a chair, an academic physiatrist who mentors students or residents, you were more likely to think that climate change was important to you, to your patients, and that we should do something about it. And also, one finding that was statistically significant was that physicians who were outside of the United States were more likely to believe that physicians have responsibility to bring awareness to the health effects of climate change. And they were also more likely to think that climate change was not only important to themselves, but also to their patients. So perhaps there was no geographic differences within the United States in our population, but when we looked at our US versus our non-US physicians, there was a stark difference. And then when it comes to waste and recycling, interestingly, most people recycle at home. Most physicians do, and most would like to recycle at work, but a lot of people just don't know how. We also didn't think that there was any difference between recycling behaviors in non-US and US-based physicians, but non-US-based physicians were more likely to recycle procedural waste compared to the US counterparts. And we didn't really have any mechanisms in our data to really tell us why that was. And I think this next slide is really an avenue for all of us to think about. So folks in our population said, barriers to recycling and improving their waste management included not knowing how to do it, so inadequate knowledge. And then encouragingly, few physicians actually felt that this topic was too controversial to address. So they felt generally comfortable speaking to their peers about it and bringing it up to their leadership. A lot of physicians also described a willingness to educate themselves, right? We're here tonight, and also a strong interest in developing formal curriculums, conference series lecture series at conferences on the topic of waste management, climate change, and sustainability. So I think this is sort of a message to all of us, although this is a microcosm of physiatry just looking at interventional pain practice. It's heartening that even in this space, people are believing that climate change is real. A lot of people think, not everybody, but a lot of people think it's important to our patients. A lot of people want to manage their waste better, but they don't know how, but at least they're interested in finding out ways in which to do this. And they're interested in developing, formal structured educational topics around this, which is wonderful. So, in conclusion, this is a huge field, whether you focus on climate change, whether you focus on waste, and it's very difficult to address all of it in the space of this lecture today. But I think it's important for us to continue to seek to understand what different groups within physiatry think with regards to climate change and waste management, because that's how we're going to start to innovate solutions. characterizing our problem is really an initial step, which, Dr. Lowe and I have attempted in a very small way, but there's definitely room for improvement there and continued work in that space. And then if your interest is education and your passion is mentorship, I completely agree that engaging trainees, medical students, residents, fellows in this topic early, and trying to see if we can brainstorm together to optimize our waste streams and our practices within our own subset of PM&R is likely a really good place to start.